A few days back, I was teaching my students. Now, I asked one of the students that how would you define rickets? And the answer that was given to me is that deficiency of vitamin D is called rickets. And I was taken aback. And I told that student that vitamin D deficiency is actually called vitamin D deficiency. And rickets is not actually defined as deficiency of vitamin D, though rickets can be caused by vitamin D deficiency. So, in other words, vitamin D deficiency itself is one of the causes of rickets. But by and large, the definition of rickets is not that it is absence of vitamin D. But anyhow, they are so closely connected with one another that I thought to make a lecture discussing vitamin D metabolism, talking about rickets and osteomalacia, as they are very closely connected with one another. So welcome to this video in which we will be talking about mostly rickets, osteomalacia, and we will be also talking about vitamin D metabolism. Let's start with the definition of rickets. Now, rickets basically is defined as defective mineralization of cartilaginous growth plates of the bone and epiphysis. Now let's dissect this definition. So see, it says defective mineralizations of what? Of cartilaginous growth plates. So if you look on the right side, this is a long bone, and the long bone has got different names to the different parts of it. For example, this long bone over here, which is the radius bone. So this end, which is the shaft, this is known as diaphysis. Then the end, which is close to the epiphyseal growth plate, that is known as the metaphysis. And this is the translucent line which you are seeing is known as physis, also known as growth plate in common language. And then we have got the distal end where most of the bone growth takes place in children, and that is known as epiphysis. So epiphysis is part which is basically most of it is distal to the growth plate. Then we have got the physis, which is a growth plate, the end adjacent to the growth plate towards the proximal side or towards the diaphyseal side is known as metaphysis, and then the shaft itself is known as diaphysis. So here physis, if you see here, is from where the bone grows. So the bone grows in both directions, mostly distally from this point. So basically this is a soft, if you see the lucency is because the bone cells are formed here. Once the bones are formed here, it turns into a cartilaginous structures, and then later on it gets ossified. As the cells are moving distally, they get ossified, they get mineralized. By mineralization, we mean that the bone cells, they get the calcium cement in that, and then it becomes strong. So strong bone basically means that it has got a lot of calcium and minerals in it, and this process is known as mineralization. So if there is defective mineralization from this end, cells are growing, and if there is defective mineralization of this growth plate and the cartilaginous areas around this area, then we call it as rickets. And because of the fact that these cartilaginous growth plates are only seen in children, they are not seen in adults, because in adults the bone growth has stopped. That's why rickets is only and only a disease of the children. While in contrast, osteomalacia is basically defective mineralization of the osteoid on both sides of the growth plate. Now, though they are related with one another, the definition is changed here. It is not only the what we call as deficiency of the what you call mineralization of the cartilage. Here it means defective mineralization of the osteoid. So osteoid means the bone that has already been formed on both sides. So this side as well the other side. So if on these both sides there is deficiency of the calcium salts getting embedded within this bony tissue, which we call as mineralization, if that is defective, then we call it osteomalacia. So osteomalacia can be present in children, it can be present in adults as well. Remember, some people think that osteomalacia is only a disease of the adults. No, it can also present in children as well. But rickets, because rickets is only and only associated with defective mineralization of the growth plate, of the cartilaginous growth plate, which is only present in children. That's why keep it in mind that rickets is only a disease of the children. You would not find rickets in adults. Once the epiphyses have closed and you've got defective mineralizations, that happens in adults, we call it osteomalacia. But At the same time, if this happens along with rickets in children, like they have got deficiency of mineralization of the cartilaginous growth plate, and they also have got a deficiency of the mineralization of the osteoid part of the bone on the both sides of the growth plate, then they would have osteomalacia as well. So the bottom line here is that osteomalacia can be seen in children as well as adults, while rickets is only seen in kids. So keep it in mind that the common misconception that rickets being defined as deficiency of vitamin D is not the appropriate definition. Rickets basically means defective mineralization of the cartilaginous growth plates and the epiphysis, and vitamin D deficiency can be one of the reasons. Sometimes it can also happen in absence of vitamin D deficiency. Rare, but it can still happen. So that's why, by and large, the deficiency of vitamin D would cause rickets, but it's not only the sole cause of rickets, as rickets can also occur in the absence of vitamin D deficiency. Thus, this is the definition of rickets and osteomalacia, and I hope you have understood that. Let's move on. Now, what is the diagnostic criteria of rickets? And what is the diagnostic criteria of osteomalacia? Like, for example, if a child comes to you who you think has got rickets, or you think you've got osteomalacia. So thinking is one thing, because obviously you would get a lead from the signs and symptoms. So a child who has got like a lot of perspiration, he feels weak, he has got bone pains, and then you find that he has got widened wrists or widened ankles, and perhaps he also got bowing of the legs, or he might have, like, sort of a bony deformities of the chest. Then probably you are suspecting rickets. But can you just like diagnose rickets on this criteria? Just you think clinically it looks like ricket and you say it is ricket? No, there is a diagnostic criteria for rickets, and there is a diagnostic criteria for osteomalacia as well. So let's go through the diagnostic criteria. So rickets and osteomalacia can be diagnosed as a definitive rickets and definitive osteomalacia, or it can be diagnosed as a probable rickets and probable osteomalacia. So there is a high probability, and then there is a definitive diagnosis. So let's talk about these definitions. So for rickets, let's start from here. For rickets, the first thing is that you must be able to see rickety changes in x-rays. So what are those rickety changes in x-ray? And I will show you the x-ray on the right side over here. Cupping and fraying of the metaphyses and widening of the epiphyseal plate. So if you look here, here is the epiphyseal plate, and if you see, there is a lot of widening. So it widens, see, and then there is also cupping and fraying. So it's fraying like this, and it's also making a cup-like structure. If you see, this is a cup-like structure. So this cupping and fraying of the metaphyseal end, and then there is widening of the growth plate. Sometimes this growth plates become so widened that it causes bony deformity, so it can budge under pressure as well, especially in the long bones of the lower limbs, and you can get genu valgum or genu varum. Anyhow, so that is also associated with high alkaline phosphatase. So when you do the biochemical test, you should always get a high alkaline phosphatase, and it should be associated with either hypophosphatemia or hypocalcemia. So you need to demonstrate that either the calcium is on the lower side of the normal. Many times you'll see the calcium is normal, but on the lower side of the normal, or there is frank deficiency of calcium in the blood, which you call as hypocalcemia. More important than that is hypophosphatemia. So even you have to check the phosphate level as well. That's why in all cases where you are suspecting rickets, you will order a bone profile. So bone profile would give you an idea of the alkaline phosphatase, it give you an idea of the calcium and the phosphate as well. So if there is a relatively deficiency of phosphate or calcium and a high alkaline phosphatase, that is another criteria that you need to make a diagnosis of rickets. And obviously then there should be clinical signs like genu varum, genu valgum. You can have abnormal spinal curvature, craniotabes, which is softening of the skull, prolonged open fontanelles in small kids, rachitic rosary, in which you find the nodes in the anterior parts of the ribs, and some joint swelling as well. So kids who have got all these four things, that they've got rachitic changes on X-ray, they've got high alkaline phosphatase, they've got low calcium or low phosphate, and they have got clinical signs, that is the definitive diagnosis of rickets. Then those who have got rachitic changes, they've got a high alkaline phosphatase, and then they can have only one of these things. Probably in early stages, Phosphates might be normal, calcium might be normal, or you might have only seen some clinical signs. So in that particular case, any one of them is enough to make a diagnosis. So you can have you need to have at least X-ray changes, you need to have high alkaline phosphatase, and then you can have either clinical signs or then biochemical evidence of low calcium or low phosphate, and that is known as a probable rickets or possible rickets. Then the second is for osteomalacia. The clinical criteria for osteomalacia, again, you need to have the same low calcium and low phosphates or low phosphates. You need to have high alkaline phosphatase levels in the blood. You need to have clinical symptoms. And if you see here the clinical symptoms, you don't need the X-ray finding. All you need is that you have got clinical symptoms of muscle weakness or bone pain. So here you do not need to have the other changes, clinical signs like craniotabes, genu varum, genu valgum, widening of the wrists, things like that. Here muscle weakness and bone pain, because osteomalacia is usually the deficiency of mineralization of the osteoid. So usually the long end of the bones would be affected. On X-rays you might find like what we call as looser zones, pseudo fractures, and that are the most common clinical symptoms of osteomalacia: muscle weakness and bone pain. They usually have got low bone mineral density. So if you do the dual absorption densitometry, it would be less than 80% of young adult mean. So what should be the mean levels for a young adult? It would be less than the bone density, would be less than 80% of that mean. Then you can have abnormal X-ray findings, or you might need to do a bone scan. So on X-rays, you might find looser zones. So like for example, on this long bone, you can see here lucencies. These lucencies can also be found in proximal femur. Here you can see it in the tibia and the fibula, and that is one of the characteristic signs of osteomalacia. We call it as loser's zone, also known as pseudo fractures. So this is needed to make a diagnosis of osteomalacia. If you don't find this thing, you can do a bone scan, and bone scan would show up like different uptake density. So on bone scan, you will see that there are multiple uptakes, like different areas of concentrations, and high concentration and low concentrations. So that also is one of the criteria for making a diagnosis of osteomalacia. So if all these features are present, we call it definitive osteomalacia. And those who have got one or two, like low calcium, low potassium with the high alkaline phosphatase, and any one of them, then the two of the other three, then we call it as possible osteomalacia. So in a nutshell, you need to do the bone profile. So you need to look at the alkaline phosphatase, the calcium, and the phosphate levels. Number two, you need to have the X-ray changes. Rickets have got a different X-ray changes. These are mostly the fraying and splaying of the distal end of the long bones, and especially one of the characteristic X-rays that we take in case of rickets is X-ray wrist. That gives you a lot of information. While in case of osteomalacia, you would be seeing looser zones, or you need a bone scan which would show up like different optic densities, and you might also have to do a bone mineral density which would show the density to be less than 80% of a young adult mean. So these are some of the diagnostic criteria required to make a diagnosis of ricket and to make a diagnosis of osteomalacia. So you should keep it in mind. Many people are not familiar with this. Okay, well, fine, low calcium, low alkaline phosphatase, high alkaline phosphatase is enough to make a diagnosis of rickets. Well, you can make it, but that is a possible rickets. I mean, this is not a definitive diagnosis of rickets. So for definitive diagnosis of rickets, just keep this criteria in mind. You might also be asked this thing on the exams or in the viva, so just keep these things in mind, and you must be familiar with the X-ray changes, and these are very characteristic X-ray changes. I think even if you see a few X-rays, you won't be able to miss these things if you look at the real X-rays. Moving on and talking about the vitamin D metabolism, because I told you many people think that rickets is actually deficiency of vitamin D. Well, in most of the cases, vitamin D deficiency causes rickets, but it's not only the sole cause. So what it has to do with vitamin D, like why vitamin D has got so close association with rickets? For that, we need to understand what is vitamin D and how does it perform in our body. So vitamin D comes from two sources. Vitamin D, number one, is made in our own body when the sunlight, the ultraviolet, rays in the sunlight, it falls on our skin, and our skin contains what we call as 7D hydrocholesterol. So this is one of the uh, ingredients in our skin, and when the sunlight falls on it, it is converted from this 7D hydrocholesterol to what we call as cholecalciferol or vitamin D3. At the same time, we also take diet which might have some vitamin D3 in it. So the vitamin D3 which we take through the diet, they are mostly what we call as ergocalciferol. This is cholecalciferol, and the ones that comes in the diet, they are the ergocalciferol. And keep it in mind that we need to have a diet which is rich in vitamin D. So most of the animal sources food products, they are rich in vitamin D. So meat, eggs, things like that, they are rich in vitamin D. Breast milk, breastfed babies, they are always at risk of developing vitamin D deficiency because breast milk is deficient in vitamin D. This is a clinical thing that you should keep it in mind, and this is one of the reasons that exclusively breastfed babies for a prolonged period of time would develop vitamin D deficiency, which might lead to rickets. So once you've got the cholecalciferol or ergocalciferol coming from diet, so you can have ergocalciferol from diet, and when it goes inside, like when you eat it, it gets absorbed, it goes into the liver. Now liver plays an important part because liver converts this ergocalciferol or cholecalciferol, which are different forms of vitamin D3, into 25 hydroxy vitamin D, which is also known as calcidiol. So there is an attachment of an hydroxyl group at 25 number position by the liver by the enzyme vitamin D3 25 hydroxylase. So this is the enzyme which converts D3 into 25 hydroxy calciferol, also known as calcidiol. So that's why if there is problem with the liver, like chronic liver disease or something, would cause problem over here, and that can also lead to vitamin D deficiency. Then initially, ultimately, that can lead to rickets as well. Once you've got the calcidiol, this calcidiol then goes to the kidney where the 25 hydroxy 1 alpha hydroxylase enzyme, and this is a very important enzyme, this converts this 25 hydroxy vitamin D3 or calcidiol into calcitriol. So now you have got another hydroxylation at position number 1. Liver did it at position number 25, kidney did it position number 1. So now you have got 125 dihydroxycholecalciferol, which is also known as calcitriol or active vitamin D3. So this is also known as active vitamin D3 because this is the one that would exert its effects and help in absorption of calcium and phosphate from the intestines. So what it does, then this calcitriol binds to its receptors and leads to changes that causes absorption of calcium and phosphate in the diet. This is important. One thing which is also important, which I forgot to mention, ergocalciferol or vitamin D in the diet, for it to get absorbed, because this is a fat soluble vitamin, it needs to have proper pancreatic juices to get absorbed. So if bile or other things is missing, then you will be having deficiency of vitamin D because your body, these vitamin D cannot be absorbed from the intestines. Also keep in mind that this 25 hydroxy D3 1 alpha hydroxylase is not only present in kidney. To some extent, this enzyme is also present in extrarenal cells, and it performs very important function in the extrarenal cell because there it is responsible for having trophic changes on more than 200 different types of genes, and they are responsible for regulating the immune responses. So it's very important for immune response, and that's one of the reasons that recently there has been a lot of talk regarding the deficiency of vitamin D and risk of dying from COVID-19. Because to survive COVID-19, you need to have a very good immune response, and research has shown that people who had vitamin D deficiency, they were many times more likely to die because of COVID-19, because this vitamin D deficiency is not only responsible for maintaining your bones healthy, but at the same time, the extrarenal production of this enzyme, which produces vitamin D3. Active vitamin D3 in the peripheral organ is responsible for regulating your immune response as well. So if vitamin D3 deficiency is there, then there is less regulation of the immune system, and that leads to a weakened immune system, and then people can get succumb to different types of virulent infections, especially COVID-19. Now, calcitriol has got a lot of effects. Number one, it increases the absorption of calcium and phosphate from the bone. It also decreases magnesium absorption from the intestines. It increases the calcium absorption and phosphate absorption from the intestines, and also causes decreased absorption of magnesium. It also decreases the parathormone synthesis and decrease parathormone secretion as well. That's why in most of the cases where the calcitriol will be deficient, there will be a lot of parathormone production in the body. That parathormone is basically secondary parathyroidism, because it tries to mobilize the calcium and keep the calcium levels constant. But this calcium comes from the bones, and ultimately the bones become more and more weak. So in a nutshell, just to summarize it, you have got some 7-dehydrocholesterol in the skin, which is converted by the sunlight to a vitamin D3 cholecalciferol, and then that is hydroxylized at 25% in the liver, and then 1 hydroxylation in the kidney to form calcitriol, which is the active form of vitamin D. And this active form of vitamin D is mainly responsible for regulating your parathyroid hormone, as well as absorbing calcium and phosphate from the intestine. So if you have got less calcitriol, then even if you are taking a good calcium and phosphate diet, it would not be absorbed from the intestines. The other thing which is clinically important is that this conversion, many people think that in those countries where there is enough sunlight, probably they would have enough vitamin D in their body. Well, research has shown that mostly it's the people lying in the tropical areas where there's a lot of sunlight who are deficient in vitamin D. What's the reason? The reason is that, remember, for fair-skinned people like Caucasians, 10 to 15 minutes of exposure to sunlight is more than enough to regulate or produce vitamin D in the body for that particular day. But for brown skinned people or dark skinned people, or what we call as people who have got colored skins, for them at least an hour of sunlight somewhere around the midday is necessary. And obviously most of these people who are living in tropical areas, they are covered. They are living in covered areas. Women, they cover themselves mostly, so obviously their skin doesn't get exposed to sunlight to that extent which is needed to produce enough vitamin D, and that's why they have got less vitamin D, endogenous less vitamin D production. And at the same time, because of poverty, the diet would also be lacking in vitamin D, so together they can have detrimental effects on the body in terms of deficiency of vitamin D. Moving on, talking about what causes vitamin D deficiency. Like obviously we say that it's one of the reasons of causing rickets, which is spraying and flaying of the bones, deficient mineralization. So what happens, why there would be vitamin D deficiency? Now, number one, the vitamin D deficiencies can be caused by different reasons. Like for example, if you look at this table on the left side, so increased skin pigmentation. The people of color, obviously, because dark skin color does not absorb the ultraviolet rays to that extent which is required for vitamin D synthesis, so they can have less endogenous production of vitamin D. Similarly, topical application of sunscreen agents. Some people, obviously, because they are more worried about their skin color, so they apply the sunscreen, the SPF 30, 50 and above. So obviously that blocks the ultraviolet rays, and ultraviolet rays are actually what is needed for conversion of this cholesterol in the skin to vitamin D3. Similarly, overclothing and living in high-rise buildings and living covered areas, these are some of the what you call environmental reasons which would cause less endogenous vitamin D production. Similarly, some of the geographical variations are living in latitude like greater than 400 north or south. somehow is a reason for and another geographical reason for vitamin D deficiency. Winter season, when you've got less sun and mostly cloudy areas, air pollution or cloud cover where the sunlight cannot properly penetrate, living at high altitudes, and these are some of the reasons which can cause vitamin D deficiency. Then people who have got decreased intake of vitamin D, like vegetarians. Obviously, I told you that good sources of vitamin D are food products coming from animal sources, and those people who are vegetarians, they do not eat anything which comes from animal sources, so they are more prone to develop vitamin D deficiency unless until they are taking supplements. Similarly, decreased maternal vitamin D stores and exclusive breastfeeding that can cause this problem. I told you why breast milk is deficient in vitamin D. So obviously, babies who are breastfed, they need to be supplemented, with vitamin D. Otherwise, they can develop vitamin D deficiency and then can develop rickets, overt or florid rickets. Similarly, those diseases in which there will be malabsorption, like where the food products, even when you consume it, are not absorbed properly. For example, celiac disease, in pancreatic insufficiency, or chronic cholestasis, where the bile is not coming. As you told you that vitamin D is basically a fat soluble vitamin. So if these are the conditions, then obviously even if you are taking good quality diet, it's not absorbed and the body is not getting it. Similarly, the body can have decreased synthesis or increased degradation of 25-hydroxy vitamin D. So I told you that problems with the liver, which causes 25-hydroxylation, so chronic liver disease, hepatitis, chronic liver injury due to immune system dysregulation or due to drugs, that can cause vitamin D deficiency. Then some of the drugs, they basically decrease or increase the turnover of the vitamin D3, like rifampicin, isoniazid, which are anti-tubercular drugs, and some of the anticonvulsants are also notorious for this thing. So people who are on these drugs can develop vitamin D deficiency. So vitamin D deficiency, by and large, dietary factors. So either the diet is deficient qualitatively or quantitatively, or there are problems in absorption in the form of like malabsorption, celiac disease, etc., or there are environmental factors like living in certain geographical areas, dark-skinned, cultural factors that can cause vitamin D deficiency. Now, there are also some form of vitamin D deficiency which are hereditary in nature, and they are vitamin D, what we call as vitamin D dependent rickets type 1 and type 2. Now, these are basically caused by problems in the enzyme which is present in the kidney. For example, the enzyme which is responsible for converting 25-hydroxycholecalciferol to 1,25-dihydroxycholecalciferol, which is present in the kidney and is responsible for converting this calcidiol into the calcitriol, which is the active form of vitamin D. If that enzyme is missing or deficient, then this hydroxylation would not occur and vitamin D3 would not be converted to active form. So obviously, when it is not converted into active form, so what would happen? The body would not be able to absorb calcium and phosphate from the intestines. That would lead to defective mineralization or defective osteoid mineralization, leading to either rickets or osteomalacia. So vitamin D dependent rickets usually is caused by this enzyme problem, and that would lead to, because that enzyme is either absent or deficient, then you have got this hallmark is that 125 dihydroxycholecalciferol, which is the active vitamin D, or also known as calcitriol, this would be low in the blood. Similarly, we have got the vitamin D dependent rickets type 2. In this, what happens? Calcitriol is normal, but the receptors are defective. So because calcitriol, once formed, it has to interact with its receptor in order to produce the changes which cause absorption of calcium and phosphate from the intestine. So if the receptors are defective, you will be having a high level, because the body tries to produce more and more calcitriol, but the problem is in the receptor. So you will be having a high level of 125 dihydroxycholecalciferol. So see how you differentiate between vitamin D dependent rickets type 1 and type 2. That is the relative levels of 125 dihydroxycholecalciferol. So it would be low in type 1 and it would be high in type 2. This is very important. The other thing is that these kids who have got type 2, they have got alopecia, patchy alopecia, and it's more common in the Middle Eastern races. So kids of Arab origin or Middle Eastern origin having rickety changes with patchy alopecia, think of vitamin D dependent rickets type 2. Clinically, you might get in exams a question: a child who is 2 years of age has got rickety changes and has got patchy alopecia. Straight away, the diagnosis would be vitamin D dependent rickets type 2. And then we have got the vitamin D resistant rickets as well. Now, this is interesting because there is nothing wrong with vitamin D, but there is problem with the urinary control of phosphate. So there's a lot of phosphates which are being lost in the urine. So one is X-linked hypophosphatemia. So this is an X-linked condition, dominant condition, and it leads to loss of phosphates from the body in the urine, and that causes hypophosphatemia. So the phosphate is low because there's nothing wrong with the vitamin D, but the phosphates themselves are being lost from the kidney. There's a problem with the kidney. Or it can also happen in renal tubular acidosis. Again, that's a kidney problem, a kidney tubular problem. Or it can also happen in Fanconi syndrome. So Fanconi syndrome is also associated with renal tubular acidosis. So in these cases, there's basically the kidney problem. It's nothing to do with the vitamin D metabolism per se. So that's why I told you that rickets is not only the deficiency of vitamin D, though in most of the cases, yes, there is deficiency of different forms of vitamin D. But as you see in X-linked hypophosphatemia, in renal tubular acidosis, and Fanconi syndrome, it's basically the renal tubules that are losing phosphates. Again, phosphates are required for effective mineralization of the osteoid and for the ossification of the cartilaginous part of the bone and for the bone growth. So obviously, when that is not there or when that is deficient, there would be rickety changes. Moving on to the lab profile, the biochemical profile, which helps you in making diagnosis, especially with respect to different forms of vitamin D deficiency. So you have to find out whether the ricket is caused by vitamin D deficiency, and if that is vitamin D deficiency, is it because of environmental factor? Is it because of nutritional factors? Again, it's because of low quality diet that's being taken, or is it because of some problems in the intestines, or is it some problem within the vitamin D metabolism pathway? So is there any problem in 25 hydroxylation? Is there any path in 1 hydroxylation, or is there any problem in what you call as at the receptor level, or is there any problem at the kidneys level? So how we do in all cases where you are suspecting rickets, you have to order a bone profile. So you have to look at the alkaline phosphatase, you have to look at the calcium, you have to look at the phosphate. Obviously, you would do the X-rays or the bone scans because you have to make a definitive or a possible diagnosis. But apart from that, you would also order certain other tests in order to see where the problem lies. So these are the preliminary tests. So the first line test would be obviously your X-ray of the wrist or the long bones. The would be the bone profile, and obviously you take clues from the clinical signs and the history. Then you can have what we call as measurements of the different levels of vitamin D metabolites. So you can check the levels of 25 hydroxy vitamin D, and you can check the levels of 125 hydroxy vitamin D, and at the same time you can check the levels of parathormone as well. So the second line investigations are different levels of the vitamin D metabolites along with parathormones. So 25 hydroxy vitamin D levels, 125 hydroxy vitamin D levels, and parathormone. These are the second line investigations. So when you combine the first line and the second line together in double form, you can make a diagnosis. For example, in most of the vitamin D abnormalities, you would see that the calcium is basically low. It might be normal to begin with, but then eventually it would go down. Phosphates would always be low, except in chronic renal failures. In chronic renal failures, the phosphate would be high. That's only one condition where would you find a high phosphate and a low calcium, that is chronic renal failure. So this is the only thing. So if you always find a high phosphate, remember, think of chronic renal failure. 25-hydroxycalciferol are usually deficient in nutritional or where the cause is in the liver. So you will find a deficiency of 25-hydroxy. In most of the other cases, it would be normal. 1,25-dihydroxycholecalciferol is usually measured to differentiate between vitamin D type 1 and type 2 rickets. So in vitamin D dependent type 1, it will always be low. In vitamin D dependent rickets type 2, it would always be high. Remember, so this is how you differentiate between vitamin D dependent rickets type 1 and type 2. 125-hydroxycholecalciferol will be low in type 1, would be high in type 2. Parathormones is usually elevated in most of the condition except in liver disease, and alkaline phosphatase, you would always find that it is throughout across the board, it is always and always elevated alkaline phosphatase, and that is one of the diagnostic criteria for making the diagnosis of rickets as well. So alkaline phosphatase is the first line. So here you can see these are the second line, and these are the first line, these two and this one. In X-linked hypophosphatemic rickets, you will find that the phosphate is always low. Alkaline phosphatase high. You might also do the fibroblast growth factor 23. That's a very expensive and a very special test. Obviously, can only be done in tertiary care or in specialized center. But remember the 25, these you see the rest of the what you call the vitamin D metabolites would be mostly normal or in the lower normal range, but the phosphate levels would always be low. And then there are certain toxicities. I don't want to go into details of that. The only one condition in which you would find low alkaline phosphatase is what we call as hypophosphatasia. So hypophosphatasia is one condition which is quite rare, where you will get a low alkaline phosphatase. In the rest of the conditions, alkaline phosphatase is high across the board. So this is how you differentiate between different types of rickets. So keep it in mind, in nutritional rickets, 25-hydroxycholecalciferol is low. In vitamin D dependent rickets type 1, the 125 is low. In vitamin D dependent rickets type 2, it is 125 is always high. Okay. Now moving on to the treatment. Now treatment depends whether you see a child who is in florid rickets or who is in overt rickets. So kids who have got like multiple bony deformities, they've got florid rickets, so obviously they require more intensive treatment as compared to someone who just have got like biochemical changes of rickets, but the x-rays or the bones themselves, they are not showing their advanced changes. So less than 1 month of age, in those kids who are less than 1 month of age, you can give them 1000 international units, and that has to be given daily for 8 to 12 weeks, so anywhere between 2 to 3 months. That, or then it can also be if you cannot give them on a daily basis, then a higher dose can be given on a weekly basis, like 50,000 international units can be given for 8 to 12 weeks. Then once the the vitamin D deficiency is addressed and the vitamin D levels are back to normal, then they have to go on the maintenance dose, and that is 400 to 1000 international units per day. Now many books, they use the microgram. So if you have to convert international units into microgram, you just divide them by 40. You will get the values in microgram. So, but by and large, most of the books these days, they use international units. So 1000 international units on a daily basis or 50,000 on a weekly basis. Again, it has to be given for 2 to 3 months. For kids who are between 1 and 1 year age bracket, 1 month and 1 year, you can give them 1000 to 5000 international units per day or 50,000 units weekly. And sometimes toss therapy, which means giving them a very high dose in one go. You can give them like 200 to 600,000 units orally, or sometimes in some countries they also use intramuscular. And once that is the vitamin D deficiency is addressed, then they would go on a maintenance therapy of having 400 to 1000 international units per day. Similarly, for older children, we give them 5000 units per day or 50,000 units weekly. Again, it's the same 8 to 12 weeks or 2 to 3 months of treatment. Or you can also give them 3 to 600,000 units over 1 to 5 days orally, and then it will be followed by 600 to 1,000 international units per day, or in some cases 3,000 units to 6,000 international units per day, who have got certain special needs, like those who are on medications which are constantly antagonizing vitamin D, like those who are anticonvulsant, things like that. So they can be given a bit of higher doses, but again, it has to be tailored on an individual basis. It's not a flat thing that you have one size fits all. You have to look at it from case to case. Also, those kids who have got advanced bony deformities like genu valgum, genu varum, they can have some surgical treatments, which we call them corrective osteotomies, for correcting these permanent bone problems. In vitamin D dependent rickets type 2, because the problem is in the rickets, you have to, and usually the calcium is very low. So in severe cases, intravenous calcium has to be given, followed by high dose oral calcium, because in this case you cannot use vitamin D, though some authorities they recommend giving calcitriol as well. But basically the problem is in the receptor. So you need to give them calcium, because in any case, even if you give them calcitriol, the receptors are not gonna, if they are dysfunctional, so still it's not going to exert any effect. So you need to give them calcium supplements in order so that the calcium is absorbed and to some extent, and their bones can be strengthened. Similarly, these days, if you ask an exam, I mean, Nelson textbook of pediatrics 21st edition mentions burosumab. This is a monoclonal antibody, and 1 milligram per kg subcutaneous every 2 weeks can be given in vitamin D dependent rickets type 2. So burosumab is the monoclonal antibodies, and again, this is the latest treatment, and it is given 1 milligram per kg. Some books even say 0.8, but again, it's rounded off to the nearest round figures, and that is 1 milligram per kg subcutaneous, and it is given once every 2 weeks. Still, sometimes it has to be given for the rest of the life as well. So anyhow, this important thing is this newer monoclonal antibody, this drug burosumab. So just remember this one if you might be asked on the exams as well. So this was all about rickets, osteomalacia, vitamin D metabolism, and how they are related and connected with one another. So it's a very tricky topic, because things are very tightly connected with one another. And you have seen, like in this vitamin D metabolism pathway, that one problem somewhere can affect the whole, the cascade of the chemical changes that are required, which are needed for proper bone metabolism. And once it's affected, ultimately it would turn into rickety changes. Ultimately, the bone would be affected, and ultimately the growth would be affected. And in some cases, immune system would also be dysfunction. So if you have liked this video, give me a thumbs up, share it with your friends. If you have got any questions, put it down in the comment section below. And please don't forget to subscribe to my channel if you haven't subscribed so far. So have a good day, and bye-bye.